all know historically when we've wanted to understand something about the nature of healthcare pricing in the United States, there's kind of a pathway you would take, right? Number one is you might call Milliman or some kind of a firm. They charge you $500,000 to answer 2 or 3 simple questions. They'd have their healthcare researchers get on it. They would use claims data. And claims data would typically be procured from one of 7 different companies that are called claims warehouses. They're intermediaries. They get claims feeds from third-party payers. And different ways of displaying those claims. Of course, you've got to be really, really careful about this to adhere with HIPAA and not let personal health information get out. But you could tell some things about claims. You could create kind of a proxy patient identifier. And to Michael's point earlier, you could see where a patient kind of traveled around. But sometimes you might not have something in that record, or maybe a patient had gotten off of Medicaid and been in commercial, so they'd only been under commercial coverage. So it was kind of an incomplete, you couldn't really get exactly to what was happening in market pricing. You could kind of give it your best guess. So rewind 5 years ago, 6 years ago, first Trump administration, they promulgate a set of rules under something called transparency and coverage. This is out of CMS. They use some existing enabling legislation to do this, so it's not codified by the Congress yet. I'm hoping it will be in the next year or two, but it does tend to have bipartisan support. And the range of different reforms kind of took a bit of a spectrum. So on one end of the spectrum, it was a requirement that hospitals had to post their charge master, or a list of prices for all the services they offer on a website. If you know anything about health, if you've worked in healthcare for like 2 days, you pretty quickly come to find out that the charge master means absolutely nothing to anybody, least of all a patient, right? Because it's not really telling them what they're going to pay or how their services are contracted or a range of things. But on the other end of the spectrum, it required transparency disclosures from 2 different parties. Oh no, Topher. Oh, it worked. Sorry to alarm you. 2 different parties with the third one in tow. So commercial insurance carriers. So let me just break that down for a minute. Commercial carriers like United, Aetna, Cigna, Blue Cross Blue Shield plans, whatever the case may be, that sell fully insured coverage to employers, and plans that self-fund under ERISA, that hire a third-party administrator, a TPA, to manage, adjudicate networks, adjudicate claims, and so on. So for everybody that insured somebody outside of Medicare or Medicaid, they had to post a file every 30 days for that network. And in that file was every single contracted provider, so every tax ID number, every provider ID number, every in-network code that provider was contracted for with a rate. And that got posted in a JSON formatted machine-readable file somewhere in the ether, not centralized anywhere. You'd have to go hunt and find it. And that effectuated 3 years ago. So for 3 years, I think 38 months now, payers have been posting these files. Non-compliance in posting these is pretty steep, and I'm gonna probably botch this because I failed to remind myself before getting up here. But the civil monetary penalties for non-compliance are like $80 per member per date. Like, it is a crazy high amount for non-compliance. Predictably, non-compliance, compliance has not been great. Civil monetary penalties haven't been enforced just yet, but we'll get there a little bit later. But these files have been out in the wild for some time. Conversely, hospitals, providers, had to post a similar JSON formatted machine-readable file in the other direction. So for every network they contract with, every in-network contracted rate for commercial coverage and Medicare Advantage, they had to post the same thing, but they don't have to do it every 30 days. They just have to do it annually. So these files began being posted 3 years ago. And I'll talk a little bit about the complexity of the files in just a minute. They've been made better over the course of time. And October 1st, next Wednesday, we're expecting to see some new information about where this administration is taking it forward. But the Biden administration effectively implemented these regulations that Trump passed, if you can believe it. And then the Trump administration, through an executive order signed by the president in May, doubled down and went even further. This is a really, really great thing. The other thing we're expecting next Wednesday is the third rail here for drug pricing. So I can actually get great drug information for drugs that go through the medical benefit because I can see that in these contracts under J codes. So there's about 200 drugs of real interest to me that I can see go through the medical benefit. Some of that could still go through the pharmacy benefit, but I can't quite see the pharmacy benefit side of this because PBMs up to this point, pharmacy benefit managers don't have to post those files. We believe and hope that's going to change at the beginning of next year, and we believe and hope that next Wednesday, we're going to see the schema for how that's going to happen. That's been delayed quite a bit, but there's enough anti-PBM fervor out there that we may be getting closer to a place where that happens. So this sounds really great, right? And like the whole idea in the Trump administration was, hey, patients can be able to access this data, so now they'll know exactly what things cost. So, we don't need this charge master thing. Well, the truth is that these files, they suck. They are really, really, if you've tried to access one of these files, this is not a pull it up, export it to CSV, run a pivot table, filter a code in an NPI, and voila, you have your answer. Like the smallest file I think we've seen has 20 billion records in it, 20 billion rows. To make matters worse, as I said earlier, they're federated, they're all over the place. So you kind of have to bring them into an environment. Well, if you bring them into a data environment, our calculation is that the aggregate number of files posted every 30 days exceeds 5 petabytes of data. To put that in perspective, take the Netflix library, all content, all countries, all languages, and a central server. This data is bigger than that. Every 30 days going into the wild. So it's a lot of information. The other challenge with this is that because there's no civil monetary penalties and the initial schema, at least for the payer postings, weren't very great, the data weren't very great. There were a lot of outliers. There's a lot of garbage. You had dentists that would wind up and they'd have contracted rates for vaginal deliveries. Not a thing that I'm aware of. You would have erroneous data. You would have ghost networks. You'd have all kinds of challenges with the data. So one of the things that happened early on was you had companies like Turquoise. If any of you have heard of Turquoise, what they would do is they'd say, hey, we can do the 4 petabytes of data storage. We're going to bring all these files in. We're going to create a flashy front end. We're going to let people access it. And people would access it and say, I think maybe there's some problems with the data. This doesn't actually match the contract that we have, or this doesn't match our experience. And Turquoise would say, well, call the payer. It's their file. We're Switzerland. So very immediately, the market started to distrust this data. We took a very different approach. I'm going to skip over that because I don't want this to sound like a commercial. But we built out some data processors and systems, which is really what you should do with this, where if you take the payer files and you take the provider files and you take the claims data, which seems just wild that you have to do this, and you reconcile those 3 different elements within a process or an algorithm, you can actually get some powerful information. And it is powerful, but it is hard to get to. So objective hope is that as CMS continues to regulate this, it will become more accessible. The challenge is that today you need people that are a lot smarter than I am to build systems that are sophisticated enough to process the data and reconcile it in a meaningful way. But the data do tell us some interesting things, and it's one more piece of a data puzzle that I get excited about. So I'm just going to show a few things that we've kind of observed from the data in a few different ways. We've looked at it in a few applications for how you can think about these data, and then I'll kind of tie it all back together in the context of the broader system. Some of these slides are probably going to be really difficult to see, so I apologize in advance. I'm not doing an exhaustive study with you guys, and I think Megan will circulate the slides afterwards, so you'll hopefully be able to get a different feel for them. So question 1 is, what can this transparency data tell us about different healthcare markets? Again, if you've been in healthcare for longer than 2 days, you've probably heard the euphemism, if you've seen one healthcare market, you've seen one healthcare market. And there's a very specific reason that we talk in those terms, because every market has two competing forces. They should be collaborative forces, but there's a tension between those forces, between who is underwriting the care or reimbursing for the care under a contract, and then who is providing the care. This is the supply and demand side of things in a market. And one of the challenges we have had in American healthcare for 40 years is, where does that market power sit? So we have an incentive problem, right? The incentive structure between payers and providers is not completely aligned, and you've had this information asymmetry over the course of time. And then you have, in certain markets, this concentration. If you've got competitive markets, and what I mean by competitive is you have a plurality of different health plans that are competing for members or enrollees, or you have a competitive health system in that you have different competing hospitals, that should create some degree of balance. And that's kind of what you see in the middle with this equilibrium. Now, I would make the case that we've never really been at true equilibrium in any market in the United States in the history of American healthcare. Even for markets that are competitive, equilibrium, market-based equilibrium, requires information symmetry. You got to know what's going on with market pricing elsewhere. We haven't known that really up until the last 3 years, but we do have that information now. So you've got this balance of power challenge that creates these distortions. If on the left, you have 1 to 2 providers that are controlling a majority of that market, they are oftentimes the ones setting the price, because they're really the only ones that are supplying the services to the demand side of the equation. So they're the price setters, and that creates a market distortion. In other contexts, you'll have 1 or 2 payers that set those rates. Fun fact, with the elimination of the enhanced premium tax subsidies for next year on the Obamacare, the ACA exchanges, a lot of carriers are leaving the market. Places like Michigan, we've gone from 5 plans that'll be on the exchange now down to 2 plans that'll be on the exchange, because nobody knows how to price for it. So that creates a market distortion that puts some power back to the payer in different contexts. But what is so fascinating about this is, you think that in an industry like American healthcare, right? There's kind of generally know what it takes to facilitate a knee replacement or childbirth. We know the different tools required, the equipment, the RVUs from the workforce. We can put together what a standard episode would look like and what that should cost. But you see this wild variation from market to market because of these market-based distortions. And when you start to look across different markets, this data can start helping to point out, well, which end of that spectrum are we actually sitting on? And I could spend, you spend hours on a slide like this, really digging into what is this telling us, because it's fascinating. The first thing that my eyes go to is, we think of Chicago as one of the most expensive urban climates in the United States. And we kind of instantly assume that, well, our healthcare must be that much more expensive than everyone else. Actually, turns out we're not terrible in Chicago. This isn't an exhaustive view of all MSAs or DRGs. This is DRG 795. So a normal newborn rate ranges anywhere from about $3,500 up to one outlier here in New York that's $17,000. Same base core cost. It's not like it costs that much more money at this facility in New York to have a baby than it does in Phoenix or Phoenix Scottsdale, but you see that kind of range. Look up at New York, and if you're familiar with box and whisker plots, if you're not familiar, just a really quick tutorial on how to read this. What a box and whisker plot does is, this bar is the median, this is your 25th percentile, this is your 75th percentile, this is your, these are the bands for your 0 and 100th percentile, and anywhere you see a dot here is just an outlier that we're not calculating in the plot, the box and whisker plot. So in New York, what you can see is a wider variation between that 25th and 75th percentile, and an even wider variation for the entire universe of data. So a very wide distribution for New York, really with one outlier. what that kind of indicates is there is quite a bit of provider competition in the market, and the data bears that out. New York's a big market. There's a lot of providers. Nobody's really consolidated everybody in that market heretofore. And this is what's really good when you see the FTC or the DOJ get involved in antitrust efforts. That's kind of the picture we want to try to create. Now, New York is still a high-cost market, so that tells you that there might be some problems on the demand side. Well, that turns out to be the case because payer competitiveness and the ability to set market rates is a bit diffuse. So you have this very just wide set of price variability that takes place in a city like New York. If you look down at Philadelphia or Flint, Michigan is a really good one. There is no variation in Flint, Michigan. So what does that tell you? Well, it tells you somebody's setting the rate in Flint. Somebody has the market power. Well, in Flint, it's the providers. There's a single provider. They own 100% of the market. They set the rate. If you want to be a payer and sell coverage and have a network in Flint, Michigan, or have access points in Flint, Michigan, this is the rate. This is what it costs us to do those things. Thankfully, they must be somewhat egalitarian because they could push that a little bit further to the north. Philadelphia, you actually have a bit of a wider competitive market on the provider side, but a very substantial concentration of commercial payers that narrows down that band. So you these types of visualizations, when you bring all this data by NPI and by payer together, start to present a picture again of how do I start to read where equilibrium is? Because the point is to try to be at the middle so the market can set the rate. We are so far from being in a world where markets set rates in American healthcare. This is a step in that direction, though. And I'm going to talk a little bit more about why here in a minute, because it links back to the other two discussions we've had today. There's a taller version of this. So where Flint is egalitarian, Cape Coral, Bellingham, Washington, Spartanburg, South Carolina, same exact dynamics as Flint, Michigan. One provider, 100% market share. They have the market dominance. They can set the rate. So look at those median rates exceed New York. They exceed Chicago. Cape Coral, Fort Myers, Florida, which is like, it's Florida, so it's nice, but it's not like hitting the lights out in terms of like bougie communities. $8,100 compared to the $3,500 in Chicago. That's a wild price distortion in the market, and yet we've allowed something like that to occur. So the first thing this data can do is it can help us better understand and compare markets so we can potentially make reforms that might be pro-competition or think about the antitrust types of regulatory structures required to maintain competitiveness in the market, right? As Americans, we kind of determined, like, let's let market forces do their thing and they'll create efficient healthcare. Well, great. Let's actually facilitate the conditions for market forces. This data starts to put us in the right direction for that for the first time in, like I said, 70 years. Then you can drill down a little bit deeper and can say, well, what does it tell us about what's happening in Chicago? And it's funny, Alex, one of my colleagues and I, who helped put some of this together over the week, we're having a discussion this morning, and you can look at these charts and you can think, like, there's just so many rabbit holes you can go down with every single one you look at. So this is a bit of a choose your own adventure thing. I'm not leading you to one ultimate conclusion. In Chicago, we have a unique dynamic in the commercial market, in that we do have a fairly diverse, we have a fairly competitive provider ecosystem, but it's based in stratas. So in Flint, for example, you don't have a cohort of academic medical centers, for-profit hospitals that are owned by private equity or HCA or CHS, and then a cadre of nonprofit, and then a cadre of safety net. You just have a system. In Chicago, we have all of those different components. And so we have a wider range, even if some of them have started to consolidate within those pockets. And we have two primary carriers that facilitate fully insured coverage for employers or function as TPAs for self-funded employers, and that's United Healthcare through a POS product that they have, and Blue Cross Blue Shield of Illinois, HCSC, for a PPO product that they have. Remarkably, in this context, the PPO rates, the median rates, are slightly lower than the POS rates. That's novelty number one. You wouldn't expect to see that. POS coverage is typically a little bit lower. So what that might indicate is that there is some market disparity between those two, and there is. Blue Cross Blue Shield has more volumes, and so they have a different strategy in terms of how they negotiate rates. You also look at the variation, and I think the next slide, a slide or two down, shows this in even a better context or detail. But you see this wider band for UHC POS and a tighter band for HCSC, for Blue Cross Blue Shield. What that means is that in a lot of cases, Blue Cross Blue Shield has a standard rates approach that they're taking across these different provider cohorts, and they're not doing a lot of variation with that. Whereas United might be a little bit more tactical with respect to how they're facilitating their contracts. Blue Cross Blue Shield has made some unique exceptions. You see this in the outliers, and you'll see this even more, I think, in just a slide or two. And then you see everybody else kind of in the market trying to figure out where they play. Cigna has tried to come in and underprice the market. They've created static rates, demonstrably through what you see in the data, but they don't seem to be picking up share because of some of the historical stuff in Chicago, and you could look at each of these and tell a little bit of a story about what's happening in our city and how people access these services. There's a different way in which you can look at this and organizing by at least three of those four cadres I shared earlier. So academic medical centers, nonprofit health systems, and safety net. I'm going to show you a couple wild things on safety net in a second. That's a part of the world you care about. It's really interesting. Top left, I have Aetna. Top right, I have Blue Cross Blue Shield of Illinois. I have Cigna, and I have United Healthcare. And again, I can see some interesting patterns here. I can see for Aetna, Cigna, and United that my medians kind of decline. For my academic medical centers, I'm paying the highest median rate for services. My nonprofits like Advocate Aurora or Endeavor, I'm paying a little bit less. And my safety nets, I'm paying less, but in the case of Aetna, wider variation. So I'm picking winners and losers at Aetna when I'm contracting with safety nets. I might think of Roseland as, I don't think of Roseland as a loser. Hypothetically, Aetna might think of Roseland as a loser and might think of Loretto or St. Bernard as somebody that they really want to pay a better rate to. And that's why you see this wider box. Same thing we showed in the previous slide with Cigna, that tighter band. Cigna doesn't really give a crap. They're just setting the rates for what they want to buy from AMCs, nonprofits, and safety nets. And they kind of run this linearly. You see where they make some exceptions for some of these outliers. United does the same thing. You can see where they've made exclusions or they've tried to kind of deprioritize the participation downstream and keep everything within this 25th to 75th percentile. And then Blue Cross Blue Shield has picked some entities that they want to pay a higher rate to, either because the quality outcomes might be a little bit better, that facility or those facilities might be better at reduced readmissions, or there might be some kind of pay for performance engagement or something of that nature that's allowing for those higher rates. But again, it's fascinating to look at the different strategies here. And on Blue Cross Blue Shield, that they would contract on the safety net side at a higher median rate than they do for the nonprofits. It just begs a lot of really fascinating questions. Well, what does this tell us about provider contracting in Chicago? So facility by facility. And so this is, we're just gonna look at two, and this is the one that's really hard to read, so I'm sorry, I'm gonna try to translate this for you just a little bit. This is the Blue Cross Blue Shield Illinois PPO, so this is one of those dominant networks that exists in Chicago. And this is the top 20 DRG rates by hospital as a percent of Medicare. So this is like a blended composite of the top 20 DRGs, so a pretty good proxy overall. And down here, anything that's kind of in this green or is in this purple is telling you nonprofit or safety net. So at the bottom, I referenced Roseland a little bit earlier. So for Blue Cross Blue Shield of Illinois, PPO, you can see right here that yes, they have included Roseland as part of the PPO network. It is a PPO after all, but they're not paying Roseland. I mean, they're paying them a sub 100% of Medicare rate. That's like literally like a Medicaid rate. You see the same thing with South Shore. You kind of see the same line trend down. The red stuff are your academic medical centers. And then you've got some advocates and other kind of more quote unquote prestigious institutions that sit at the top. But you see where HCSC has kind of made decisions. They tend to live in this area for folks where they want to kind of disincentivize the rate and hence coverage. You'll see them fall closer to this end. And then you'll see for these areas where they might perceive better quality, differentiated services, differentiated contract, value-based care, they might pay a bit of a higher rate. 100%. It could vary. So since this is commercial, you won't see the stars, I think, show up in the data, but I think it's absolutely right that Medicare sets so much of the tone for how contracting gets done across the country that yeah, you look at stars, you look at HEDIS, you look at other outcomes measures, and you might make the determination that I'm doing a lot of volume with you, you're doing good quality, or the provider may have said, hey, we're a lot better than anybody else, and we're not gonna be in your network unless you pay us this rate. But you only ever know that when you look at the data market by market to understand the unique nuances. So that's what starts to make this really fascinating. This is the same view, few more providers, but through that United Healthcare Choice POS plan, and look at like how tiered this is. So this almost looks like they were sitting in a conference room and they made the decision to create these segments, these cohorts and buckets, because you see all the safety net hospitals down here, all south of 100% of Medicare commercial coverage. Then you see the nonprofits kind of cluster up through here. And then you see the academic medical centers kind of trickle up above. And again, shows that how these organizations are choosing to facilitate these contracts. And again, I'm just gonna point out that for the nonprofit and the safety net systems, to be at an aggregate on your top 20 DRGs of 100 to 150% of Medicare, that's insane. For commercial coverage. You'd expect it for Medicare, you'd expect it for Medicaid. Commercial, if you're not hitting at about 190% of Medicare on a reasonable commercial book of business, you're in trouble. And this shows that market dominance, that power truly is being set by these two. So where you might have in Illinois, all this competition with all these different networks, for whatever reason, there are two networks doing about 75% of the enrollees, the claims adjudications, the network facilitation, and hence you've got this kind of pricing distortion that occurs in Chicago. So moral of the story for a place like Chicago you'd want to think through is lower healthcare prices. We need to find a way to be more competitive on the insurance side and create more variability, optionality, which will then in turn be good for providers and create some sustainability downstream. Or you could ask one of like a million other questions and dig into the data, and it's going to start to tell you a story. We've never had data like this before. And this is what I get so excited about because there's all kinds of applications you can use with these data. I'm gonna skip that for this morning. We've been working with this data now for about 3 years. And we've helped clients facilitate negotiations. So we have one example of a client mental health clinic that said, hey, we're pretty sure we're not getting paid at parity with these guys down the street with Aetna. We looked up, sure enough, they were off 10%. They get on the phone with Aetna and they say, hey, we think these guys up the street are getting 10% more than us. And Aetna says, nah, we promise you they're not. And they said, well, actually, your data says that they are. And Aetna said, well, let us call you back. And I call them back 2 weeks later and they said, you know what, you're right. Our error was a data problem, like some intern. We're gonna gross you guys up. And they got a better rate. Like we've seen that happen over and over. So cool when you see that happen, by the way, for safety nets and mental health. Case rates. We used to have to set case rates or bundles or capitated rates on the basis of what we saw in claims. You can actually now use pricing data. I can benchmark with a good grouper rates from other networks, claims data, and core RVU data, and I can give you an incredible estimation for which providers might be hosing a payer or which payers might be hosing a provider. Network navigation, we have data flowing into a tool right now where patients select a provider based on the cross-section of the cost and the quality. So that payer has said, hey, if we show you, patient, looking for care, where the best quality place is, if you pick one of those places, we're gonna give you a discount or a rebate. That is working. We can actually do stuff like that now. Network modeling, we have brokers actually out working with employers and saying, you're doing all your business at Duke. If you moved it over to UNC, you would save this amount of money based on the claims volume you're running and what we see in the pricing data. Real time happening right now. If I want to expand markets and understand the market dynamics of a different place to do M&A or to expand my services, I can do the same. And again, regulation or antitrust, seminal, a really incredible tool for government to use if government could put together the right systems to use these data and analyze them in the right way. The thing we've put together is something called StarSet Analytics. I never do infomercials in any talk I ever give, but I will say we have a platform that maps this data out. So if anybody's interested in that at all, let Megan or somebody know at the tail end. I'm gonna bring this together and turn it back to Megan. I think the thing I'd like to leave you all with this morning is that this is a super complicated moment. And as I said a few minutes ago, I think we are, for the first time, we are seeing the wheels start to come off of the system. It's gonna start at the safety net, but starting next year, there is no more employer commercial cross-subsidization, bail everybody else out game. We have fixed government rates. We're in a soft labor market. Commercial carriers are gonna think and engage differently. The size of the $5 trillion annual pie, it's not gonna continue to increase. My point of view is that that is going to make everybody fight more fiercely for the dollars that are in the system. And fighting for those dollars in the system will require an alignment of financial interests. An alignment of financial interests is code speak for value-based care. And the things that will enable, supercharge, make possible value-based care is the ability to set the right price, conjoin it with the right quality, and then have the right access to the right clinical data to support the responsibilities that you have to deliver those outcomes for that patient. So on the one hand, I'm actually excited that the healthcare system is under a lot of pressure because to Michael's point earlier, that might be the catalytic thing we need to get off our asses in this country and do what we do know how to do. We know how to build value-based models. We haven't had the data that's allowed us to do that on the pricing side and to support management of patients. And I think because of the existentiality we're walking into, that will be a path for the market. It's either do that or wait for government to step in and fix it. And we probably have a few more years until we're stable enough as a nation in the political process to see government play a meaningful role. We're gonna have to lead in the private sector. We're getting the tools, but there's a lot more work to do. So I apologize, that was a lot to jam into an hour and I didn't leave any time for Q&A, but you can grab my colleagues after, or you can reach out to me when the meeting's done. And Megan, I will pass it back to you.
Thank you, Dave.